Assalamu alaikum. Welcome everyone on board. uh,
Welcome, sir.
Today, it just struck to my mind to have uh, a very practical uh, situation which all of anesthetists face. That you have a patient which is uh, like uh, which is supposed to be coming from ICU, okay, and you are undergoing because there will be so many scenarios which can be made, but there are few general principles which you should be taking care when you are receiving any patient, because there will be common things which will be there in any patient you are receiving. Okay, usually that indifferently these patients will be unstable usually. Okay, overall, but and maybe they are finding a window in which they are doing that surgery. Okay, this is one option. And the other option is that there is some acute decompensation which is warranting surgery. Okay. For example, the example for this will be that there was a patient in ICU in shock, and now this patient developed acute uh, ischemia anywhere, probably, for example, if I just take it, for example, gut ischemia. Okay, because of patient was on inotropes, and patient developed gut ischemia. Okay, so this will be one probable scenario in which you have to do the surgery. Okay, like another scenario will be that the patient had some wound uh, which was remained open, which was open, or now they want to close the wound because they want to wean the patient off. This will be a one scenario. Okay, then there may be some frequent dressing wounds which they are not doing in the ICU. Okay, so one reason or other, I just want to highlight in this discussion that what you should be looking at, what we should be expecting. Okay, so now if you are receiving a similar patient, what you can expect, any volunteer who can just have some interaction. Yes, Irfan.
सर एयरवे से स्टार्ट करेंगे कि if the
Talk in
patient is
English,
in
please.
ICU.
Talk in
Yes, sir.
English,
So
please.
we'll
Okay.
start from the airway. We'll
Airway,
see if
airway or
we'll
here
see if
a
the
little,
patient
there
is
will
all.
be a little different approach will be, because you will uh, should you start from the conscious level or no?
Yes, yes, sir.
In this scenario only, of
GC.
course, your approach is absolutely fine. Okay, but because you are expecting this patient to, maybe the patient is sedated, ventilated, paralyzed, so your focus, or patient will be disoriented, or patient will be like of course, I'm just trying to have a very broad discussion. So of course there will be in different scenario, the things will be different. So like, before going to ABC, you may have some words about conscious level and whether the patient is sedated, or whether the patient is not sedated. Okay, so and then of
Okay, sir.
course airway, whether that airway is maintained spontaneously. Okay, or there is some support. So what can be
Yes,
that
sir.
support?
सर इसमें सर
The patient may be on endotracheal tube or tracheostomy. Okay,
all right, sir.
or
Yes,
or
sir.
maybe, for example, in special scenario, BiPAP. Okay,
Yes, sir.
if it is a spontaneous patient, of course it will be according to the FiO2. It will be Please, whosoever is not speaking out, I request you to mute the mic. This is like very irritating thing. Anyways, so when it is spontaneous, patient may be on without face mask, patient with maybe with nasal cannula, patient may be with the normal face mask, patient may be with face mask with reservoir bag without rebreathing bag,
Right.
or face mask
Yes,
with
sir.
reservoir bag with non rebreathing valve. Okay, so this may be a scenario, or uh, recently with reference to COVID, patient may be on high flow nasal. Okay, or
Okay.
there is one more thing, venturi mask. In this, we are revising a number of common things as well. But you should be looking at it, that how you are receiving the patient. If, for example, patient is with mechanical ventilation, so you will be looking at the parameters. Usually, what you should be asking, that is it on high ventilator setting or
Mhm.
low ventilator setting. Okay. So usually it will be related with reference to FiO2, with reference to PEEP.
Mhm.
Usually, okay, which they say that patient is on high FiO2, patient is on high PEEP, because what will be the problem? That ICU ventilator is more advanced, and you have more modes of ventilation, which will not be there in the during the transfer. That will be even either they are shifting with the patient with the portable ventilator, or they are shifting the patient with the ambu bag. In either of the situation, the patient will not be able to be in stable condition in this scenario. Okay. So whenever you are receiving a patient with high ventilatory settings, high FiO2, PEEP, etc., high airway pressures, or whatever the patient can have ARDS. Okay. So you have to immediately, whenever you are receiving the patient or you are having the patient, you will be looking at PF ratio, which will tell you a number of things. Okay. So in addition to FiO2, PEEP, and you will look at the PF ratio, that where the patient is. If the patient is having good partial pressure of oxygen on low FiO2, it means you are on safer side. Okay. So this is just your mind exercise, that whenever you are receiving a patient with reference to respiratory system, you will be looking at these things. Patient is on how much is FiO2, how much is PEEP, how much is PF ratio, are the lungs ventilated? Of course, you can correlate it with, you will be correlating with ABG's chest X-ray. This will be minimum thing which you will be looking at. Okay.
Yes,
So
sir.
this will be minimum you will be looking at. Okay. What else? What else you will be looking at with reference to anything we can add in the respiratory system?
Uh, Regarding circulation, Assalamu alaikum, sir. Abdul Shakur here.
Yes.
Yeah, I appreciate you. This is a very most important topic which you have chose. Being an intensist, what we are facing, those patients are going to be in a shock likely, especially in the
Yes.
elderly patient. Those are in the hemorrhagic shock, and they require the pressures like one pressure, another pressures. Then after they develop ischemia.
Yes.
What we see, the peripheral ischemia is common. So the question is here, peripheral and sometime, digital upper limb as well as for the vasoconstrictor medications. The problem is here the monitoring. If the
Okay.
patient is you are hypotensive, still he require the double inotrope supports. So the challenging for us is to how to invasive monitoring for this patient actually. So it is also important to be.
Yes, yes. With reference to, I think we have covered. If we missed anything, anyone can add on it. But usually, with reference to respiratory system, you will be looking at these things. Then come the cardiovascular system. The weather, you will be looking at usually at the blood pressure, heart rate, signs of cardiac output. Okay, so like signs of peripheral circulation and rhythm. Okay. So like usually these three, four things you will be looking at. and like what will be like, you will be looking at oxygens. Actually, you see, sometimes you miss a very simple thing with reference to PF ratio and FiO2. The result will be in the form of SpO2, of which I missed when I was telling you respiratory system. Anyways, so you will be looking at these things and you will be saying that are these parameters spontaneously maintained, or you are giving us some push with inotrope, okay, push with vasopressor, okay, push with, for example, like you can expect anything. There is some pacemaker, pacing lead, there may be intra-aortic balloon pump, or maybe patient on ECMO. I'm just giving you a maximum scenario. Of course, you will never do a surgery in that scenario unless, so what for just for your mind exercise, you should be looking at, there may be ventricular assist devices. So patient may be spontaneously or by some support. Usually these two things will be common. These things will be rare. Okay. But you should be knowing that whether how these cardiorespiratory parameters are being maintained. Okay. So this thing will be there. And then now comes a number of simple things for example, for sedation or paralysis or analgesia. Okay. So before going to any medication, you should be looking at the lines. So you will be having IV line, arterial line, like central line, okay, Foley's catheter, NG, okay. So like you should there any drains, okay, chest tubes or any drains, okay. So when you are receiving you should be knowing how many lines are there. Arterial line is there, CVP is there, Foley is there, NG is there, okay, and drains and chest tube or anything you can add on to a number of things. And then what medications are being given for sedation. Like for example, you will be having a patient with fentanyl or midazolam, okay. Usually whenever patient you are receiving, they will be jumping. I have never seen, even in very good hospitals, being received in a very stable condition. Usually when you receive the patient from ICU, usually because they have like phobia from using of muscle relaxant, but actually when they are transferring the patient should be relatively stable position. Why? Because if patient is moving, the tube can be dislodged. And if you are in out during the transfer or in between, if the airway is dislodged or patient is moving, and during shifting, there can be a lot of problems. So ideally, these patients should be adequately optimized and in a stable condition with reference to cardiovascular respiratory, of course, taking care of these things. But these patients usually should be stable enough to be transferred, because otherwise if patient is fighting, you can have a disaster, because the bed from by which they are transferring the patient will not be an ideal one. There may be you should be taking in consideration these things, okay. Usually fentanyl, midazolam, propofol, okay, dexmedetomidine, you can expect. So you have to make sure you should be knowing the concentration which you are receiving, the rate you are giving, okay. Because, and another thing is that sometimes the lines are blocked and you happen to flush the line, and now either a bolus has gone. So you should be very clear about which line is receiving which thing and how much rate, and whether this line is functional or not. Because sometimes they stop the syringe pump, and when they stop the syringe pump, the lines are blocked. And when you reopen, so they're different anesthetists do in a different way. Sometimes they would prefer not to use these medication, throw them away, or there will be some people who rely, if there are standard concentrations which are there in the hospital as a protocol, so there is no harm in using this medication, but they should be properly labeled, and you should have a proper endorsement related to the lines which are being used, okay. So whenever you are receiving any patient, please make sure you have proper information about these things, because in the when they will give you the gift and they will run away, and after that the patient will be with you. So anything which happened after that will be your responsibility. Okay. So you have to be very careful about these things. Sometimes you see Foley's. I'm telling you a very simple thing. Foley's during transfer, it can pull, it can cause a urethral stricture, urethral injury, or even if the patient survive from the thing, he will have rest of life with urologist. So this is something very, very dangerous, that Foley's should be properly fixed when you are transferring the patient. Okay. Or you are taking, when you are receiving the patient, you should take care of all these things. There should be someone who's responsible for this handover takeover. Okay. Then they you can have, because now there is no exact scenario. It will be in different patients. Something will be there, but in some other patient, other thing will be there. But usually you should be knowing about the DVT prophylaxis patient receiving, about the glycemic control, the usual endorsement which we take about any patient. But here you, because your intake output, how much positive or negative balance patient is having. Okay. And pressure, any bed sores. Okay. If the patient is on, for example, with reference to DVT, maybe patient is on constant, patient may be on constant. uh, it was a lot of noises coming. Dr. Abdul Samad Khan Tareen, please can you mute your mic? People don't understand. I'm being distracted with this thing. What should I do? Dr. Abdul Samad Khan Tareen, can you just mute your mic, please? Okay. So you will be looking at these things generally, and you will have an overall, and then of course the rest of the things will come after that. Because you can have a patient in shock with the high inotropes. You may have a patient with the bleeding, shock, high ventilator setting, as I told you. Okay. And you will be dealing according to that case. But usually these are the common things. And yes, if you have a patient with head injury, there may be this one head this neck collar. Okay. So you have to be taking care of these things. Of course, these are the common thing which you are dealing when you are dealing any patient coming to OR. But of course, because we are I was discussing these common things, please can anyone add to something which I have missed? Transportation importance. People can say no transport unless it patient is stable enough. Of course, this is not an absolute thing. They will outweigh risk versus benefit. Okay. So for any procedure to be done or not to be done, of course there are certain things which are important. But usually, if for example the patient, you are losing the patient, so in that scenario, and there is possibility that if you do that surgery, maybe there is a chance that the patient can survive or patient can improve. So definitely they will try to do it, because but that will be considered at 5E. Okay. You will consider that patient as 5E. Any comments, anything to be add? I'm sorry, I have no other
Sir,
option than to repeat. Yes, Irfan.
If the patient is in shock, the patient could be in renal failure and could
Yes,
be on renal
CRRT.
replacement.
CRRT. Okay, thanks a lot. Anything, please, Zishan, or anyone wants to? Yes, Irfan. Anything good point I missed. I missed about it. This thing. What else? Patient may be on CRRT or coming after dialysis. Okay. What else? Anything, please, Zishan. You joined late,
So
but
sorry, I joined late. I don't know exactly what you have
actually
talked.
we
And
are
Dr.
just
Bilal
dealing.
Patel is here. I
Yes.
think you can
Actually, I will
take a
just tell
comment
you the
on it.
background that we are discussing a scenario in which you are receiving a patient from ICU for any surgery. So that what are the general basic principles you should be taking here. So I just discuss in a way that there are certain things whenever you are receiving the patient, according to the conscious level, whether the patient is maintaining the respiratory system spontaneously or with some support, either it is endotracheal intubation or the patient may be on tracheostomy or the maybe patient is on any oxygen delivery device according to that thing, and then you will be evaluating according to the what is the status of the patient with reference to respiratory system. So you will be looking at the FiO2, you will be looking at the PO2, you will be looking at the oxygen saturation, you will be looking at how much PEEP is there. So you will decide whether this patient is, because the ICU ventilators are advanced one and those functions are sometimes not available during the transportation or the ventilators which are there in the OR. Okay, so this will be a big challenge for you to manage the ventilation of that patient. So if the patient is having low ventilator setting, so that will be an easier job than a patient with high ventilator setting. This is one thing. With reference to cardiovascular system, again, you will be looking at the cardiovascular system with reference to the general parameters, blood pressure, heart rate, and cardiac output. And then you will be looking that whether this is with spontaneously or with some support, like any inotro, vasopressor. So you have to make sure the lines through which these medications are going, you have to take. I think you have listened to these things. You just joined now, am I right? Yes,
Yes,
Ishan.
sir. Another thing was that if the patient is in need of some special ventilator, then the ICU ventilator can be used in the OR and the case can be done under TIVA.
Yes, you are right. Anyways, these
Yes,
are,
sir.
there are so many
Another,
things which may be added to this thing. What else,
yes,
please?
sir. Another thing was that in sometimes if a patient is critical and he is DNR, then it is asked that what will be the DNR status during the operation because you might have to intubate and all that stuff. So in that case, the DNR is temporarily stopped
Temporarily
for
paused.
the duration of the
Yes, very
pause.
good.
Yes, sir.
Yes, very good. So DNR status, usually if they are doing anything to just ease down the life, or they are doing something, they will ease out the DNR at that time. Very good. What else? Glycemic control, I told you. DVT prophylaxis, I told you. Intake output, I told you. CRRT was added. Um, I think that's it. So because you will be looking at the whole overall scenario, of course, the primary disease will be there. The surgery which they are doing, will the consideration with reference to that surgery will be there. Usually, whenever they are doing any surgery, they are doing it as a life saving one, or they are doing it as a long term management one. Okay, so I think that's what I wanted to share with you for today. So thanks a lot, all of you, for attending. And any point, any comments, anything you want to add, you're welcome. Yes, Irfan.
No, sir, nothing.
Okay. So even after that, if I had missed something, please you feel free to ask anything, anytime. Thanks to Dr. Akhtar Wahid to join us also. Jazakallah khair. Okay, thank you very much. We will come back with some new topic, inshallah.